Hello, I'm Dr. Anthony Mazzella. I'd like to welcome you to our continuing education seminar series on understanding and treating the challenging, personality disordered patient. Throughout this comprehensive program, we will delve deep into the various facets of personality disorders with a particular focus on narcissism, examining each facet from different psychodynamic perspectives. In each one-credit seminar, we will explore a particular, challenging, or narcissistic trait, think about its origins, and finally, through case examples, how to successfully treat the specific narcissistic trait under discussion. This comprehensive approach will lead to more effective treatment outcomes and healthier interactions. In today's seminar, we will start by initially defining what is meant by the challenging patient. From there, we will identify the signs of narcissistic personality disorder. Recognizing these signs is crucial, yet it is just the beginning. Let me show you what I mean. Let's jump right into it. What do you think about when I say, and I quote, the challenging patient? What makes a patient challenging? What about the patient who defeats your efforts to help? And by the way, this is a very common narcissistic trait. Or what about the patient who has no interest in changing or trying something new? Or what about a patient who does not collaborate with you? In other words, there are not two minds working together to understand something or solve a problem, but a general feeling that you should be fixing things or making things better for them. Again, another common narcissistic characteristic that we must discuss further when I talk about intervention techniques. What about the patient who attacks you, is angry, or devalues what you say, mocks, or dismisses your comments? Again, yes, I think you're seeing this, another common narcissistic trait. And in fact, this is what we consider to be at the core of NPD. So at some point, we'll have to talk about this in much more depth, but this is known as the grandiose sense of self. Okay, what about the patient who demands immediate gratification with the expectation that you will solve all their problems quickly? Or the patient is not committed to treatment, is not invested in the relationship, misses appointments, comes late, or leaves early. Finally, what about the patient who passively complains but does not lift a finger to change anything in their life? Do they fit the label of a difficult patient or a challenging patient? And by the way, this list is not exhaustive. I'm sure you have ideas in your mind as well in terms of what you would consider to be a challenging patient. Does any of this sound familiar to you? And if so, how do you usually handle a patient who, for instance, does not seem interested in change or is not collaborating with you or your treatment plan? What strategies have you found effective or ineffective in such cases? Let me address some of these questions with a quick example. When I was in graduate school pursuing my doctorate degree, I worked in a dialysis unit, providing treatment for patients with kidney failure. The dialysis protocol required patients to undergo dialysis, and in case you're not familiar, dialysis is for people whose kidneys have failed. So they need to go to a facility typically and get hooked up to a machine that acts like an artificial kidney. And the protocol typically is very rigorous. They need to go 3 times a week for about 4 hours per treatment. Despite this, some patients would either skip sessions or cut them short, leading the nurse and staff to label them as, and I quote, non-compliant, and become increasingly frustrated with their behavior. During this period, I was also immersed in my psychoanalytic training, where I learned that behaviors like what we were calling non-compliance were merely symptoms of deeper underlying issues. This perspective prompted me to delve into understanding the reasons behind these patients' decisions to skip or shorten their treatments. I found that there was very little research demonstrating effective methods to improve adherence to dialysis protocols. While several studies had attempted to increase adherence, very few were successful, and those that did demonstrate some success, there was no follow-up. Many studies demonstrated that simply educating patients about the consequences or the dangers, in other words, of skipping or shortening their sessions was ineffective. So in other words, if the intervention was to educate them about how they're going to get sick and they're going to retain fluid, they'll end up in the hospital, it puts extra pressure on their heart, et cetera, et cetera. None of that was effective. My psychoanalytic training helped me appreciate the importance of understanding the subjectively importance of the non-compliant behavior. In other words, what I'm trying to say is that they were skipping their treatments for good reason. Now, I know on the surface that must sound very strange to you, but I had to keep in mind that this non-compliant behavior was not the problem, but rather a manifestation of other issues, right? So in other words, this was the outcome, the symptom, if we could call this the symptom, if you could think about it this way, is not the problem, it's the outcome of the problem. But what are these issues? In other words, what's driving the quote-unquote non-compliant behavior, you may be asking? Can you picture this scenario? Session after session, week after week, month after month, a patient of yours comes in complaining and says in a defeated tone, nothing is changing. She can't, you can fill in the blank if you know a patient like this, but she can't, for instance, write her reports for work and is in trouble again with her supervisor. When you hear that, what's the urge? My urge would be to help her get organized, to write her notes, right? Or the urge may be tell her what to do. But the problem with that is you have now just stepped into a role. And there are different names. If I could borrow from psychoanalytic theory just for a moment, there are different concepts to describe this phenomena. Role responsiveness, projective identification, or sometimes we call it an enactment. They all have in common a few things. That you are feeling a certain way. In other words, you get an urge to do something, to take an action to help your patient. And therefore, like those nurses in the dialysis unit, you try to get your patient to do something. In other words, you're taking an action, but you're also in your action trying to get your patient to take an action. What if you now recognize this? And what I'm saying begins to resonate with you, right? You are now in a better position to think about what is actually the goal here. Is it to, and I quote, get your patient to stop acting in a certain way? Again, some people refer to this as acting out, right? To stop missing their dialysis sessions or to write her reports? Is that the goal? Is the goal, therefore, we could say, to turn this patient into, and I quote, good patient or a non-challenging patient? Have you ever encountered a patient who seemed eager to please and was compliant, but later revealed deeper, more complex issues? What I'm suggesting is you have to be very careful with, and I'm quoting, compliant patients, like the good patients. Such patients often present what is known, again, to borrow a term from my field, the field of psychoanalysis. This is known as the false self. These are the patients who don't feel safe enough to express their genuine emotions and thoughts. But you may be asking, what about the patient who comes on time, is eager to learn, accepts your interventions, is very interested in change, and actually makes dramatic changes quickly while always expressing a great deal of appreciation for you? To that, I would say you have to be careful, because in my experience, and this is also well documented in the literature, the paradox here is this is usually a patient who's looking to please you. This is the kind of patient who pleases people. This is like the overly agreeable patient. I wrote about this, or I discussed this, I should say, in a podcast episode. I did an entire episode on the agreeable patient, which is also known as the false self. And this dynamic, therefore, is indeed, and this is another form or iteration of a challenging patient, right? That this becomes challenging in and of itself. On the surface, it seems like this is the dream type of patient. But if there's this false self, right, what you get then is a compliant patient. The perfect patient may actually be presenting to you their false self. Herein lies, again, by the way, the overlap. This is the overlap with narcissism. The false self is a common trait amongst those suffering with NPD. And we'll have to talk about that in much more detail too as we go along in this seminar series. So what's the main point here? The challenging patient is typically the one who is not doing what you think they should be doing. In the dialysis unit, they called them non-compliant because they were frustrated with the patients who were skipping their sessions and getting very sick. A question I typically hear is, what can you do to make the patient less challenging? No one can make a patient do something. So that's the first thing I want to say about making the patient less challenging. The patient is free to do, and many patients come to me after this, like after a treatment, and that's why I really want to express, the patient is free to do what? Whatever it is they need to do, right? In these two examples that we're discussing, it's skipping the treatment or not writing their reports, their notes. The patient is free to do that. What will happen is, and I've heard this from many patients who come to me after a treatment that they were in prior to seeking me out, that they get stuck in what we call an impasse. In other words, the treatment isn't moving forward. And I often hear when I explore this very closely, because I want to understand what led to the impasse, that the therapist was trying to get them to do something or to give up something. These are the kind of interventions you hear, like somebody who doesn't have any friends or hobbies, and the therapist is trying to encourage them to get a hobby, right? Or to socialize more. And what I'm suggesting to you, and I hope you can consider, I know this might be a very different way of thinking about this, is that we shouldn't try to control or coerce the patient to do anything differently. For those of you who have listened to my podcast, you know what I typically try to demonstrate is with this kind of patient, how the technique would be to appreciate the patient's subjective experience. And I think I've called it appreciate the subjectively useful component of a maladaptive symptom. Now, I know this is probably a little confusing because the symptom is maladaptive. Like I mentioned, patient staying home, not socializing, the other patient not writing the notes is going to get in trouble with the supervisor. And very seriously, the patient who's missing dialysis will end up in the hospital. We've shown I should say, it's been shown that there's a relationship between missed sessions and increased morbidity and mortality. So why would I be saying accept and appreciate the subjectively useful component of a maladaptive symptom? But what I want to emphasize is that this does not mean that you agree with what they're doing. It does not mean you condone the behavior. For instance, the dialysis patient's behavior of skipping their sessions, but you want to understand it from their experience. So the intervention that I put in place in this study that I did, which was also my dissertation, was I designed a study where half the patients who were skipping or shortening their sessions got a social work intervention of education. Then the intervention group, which was the group that I was working with, is I would sit down with them and try to understand their experience of being on dialysis and what that was like for them. What was their experience of it? And they never spoke about that before because they have all the medical staff just telling them what they need to do. I put need in quotes. In other words, what I'm suggesting is initially to accept the patient on their own terms, even if that means that they're doing nothing or they're sitting home watching TV or engaging in some compulsive behavior. This is the character. See, this is the personality. This behavior is part of their personality. And the goal is to understand what this is all about, how it works for the patient. If the patient is, for instance, condescending, for instance, right? Think about a real critical person or patient in your life. It serves an important purpose. So what purpose? Just as, to play around with this a little bit. If someone is condescending, what purpose does that serve? So again, if we're thinking about narcissism, there's this old saying, a superiority complex to defend against an inferiority complex. So the person who is condescending is superior, right? But oftentimes that's a defense against feeling inferior. And this is the stuff we need to appreciate rather than just quickly trying to get them to give up some behavior. And this is why treatment takes time. It takes time because we have to learn to respect the patient's subjective experience. This is the patient's truth. But wait, you may now be saying to yourself, but these are symptoms. And isn't it the goal to get rid of or reduce these symptoms? These are problems. This is a big problem in the patient's life. Okay, so you're saying that these are the symptoms and isn't the goal to get rid of the symptoms? To that, I would say, be careful not to push the patient to give up their symptoms. This is what leads them to be what we call the more challenging patient. This is actually what leads to a patient being challenging. If you want to take away symptoms, you have to understand, even though the patient may complain about them and not like them, these behaviors are still part of their personality. It's part of who they are, and they will lose a part of who they are And if you press the issue, they will hold on. They'll hold on for dear life. It's like giving up an arm. You don't easily give up a part of you. You're not going to give up a limb. You're going to hold on if somebody's trying to take this away from you. And you're going to fight. And by the way, we saw this in the study that I was just referring to with the dialysis patients. And it's very common. And this is even given a name. It's called the boomerang effect. So what we saw, for instance, is the intervention group. That's the group that I was sitting down with and I was talking to them, understanding their subjective experience of what it's been like living a life with kidney failure and having to go to this treatment 3 times a week. The intervention group, by the end of the study, compared to the other group, which got that educational information, had decreased their non-adherent behavior by close to 300%. So there was almost a 300%, a threefold increase in adherence to treatment, where the comparison group got worse. In other words, non-adherence went up. They skipped more sessions. They terminated more sessions early. So the group that got educational information became more non-adherent. And in fact, this was consistent with what I was looking at in the literature. So I wasn't the first one to demonstrate this. And then what happened is, after the intervention was over, we continued to monitor these patients. And what we found was the group who got the education, right, like being told what to do, they slowly returned to baseline, which was their normal level of non-adherence. But the intervention group continued to show increased adherence. So in other words, they continued to miss less and less of their dialysis treatment, if that makes sense. So what's the point? Why am I telling you this? Because I'm really trying to drive home, because we're talking about the challenging patient, and in part, what makes the challenging patient is coercive pressure for them to do something differently. And when you put that pressure on them, that's when you get the boomerang effect. So therefore, the goal, the aim is not to remove symptoms. The goal is to prioritize, in my opinion, self-understanding and the capacity to think about the choices that they are making. The goal is to help the patient think in new ways, to think about things that maybe they have not thought of before. But here I want to try to be very clear. When I say don't push them to give up their symptoms, I don't mean you are passively sitting by, listening and reflecting on their experiences. In other words, it's not like you're trying to be a good friend who's giving advice, is very empathic and holding. No. Effective treatment involves much more of you. We have been talking about what I find to be ineffective when working with these challenging personality disordered patients. But I want to do a little more to clarify what I'm suggesting or what my perspective is on what's effective when working with these patients. Some challenging patients have difficulty symbolizing. Again, this is another narcissistic characteristic that we need to get into. Perhaps in a subsequent seminar, we'll pick that up as well. But what does this mean? They have difficulty symbolizing. This means that they cannot easily see or make connections. In other words, they can't necessarily say, I am missing my dialysis treatments because I feel trapped when I'm on the machine. And when I was younger, I felt like my mother always trapped me. You see, that's a big leap for somebody like this, for somebody that does not have the capacity to see that there's meaning behind their behaviors, that this behavior comes from somewhere, even if they can. And by the way, some of them can say this, right? Some patients, some narcissistic patients have a great deal of insight and they understand things and they make connections and they know they've had a difficult upbringing, but they know it on an intellectual level. And therefore, it does not really change their behavior. Like I've heard this so many times that, oh, I'm projecting, but that does not stop the patient from projecting. They could say things like, I know that people are not really judging me, that I'm projecting, right? But yet they can't get out of their house or their apartment because they feel so judged by their neighbors. So what I'm saying is making these links, right, can bring some sort of intellectual or cognitive understanding, but that doesn't necessarily lead to change. So what does this then mean in terms of a way that you can intervene that holds the potential of being much more effective? Let me answer that question with an example. Take, for instance, patients who have a long history of trauma, have a fragmented sense of self, and are prone to splitting. Splitting is just that all or nothing thinking, which you may have heard of, right? So people who use all or nothing thinking, everything is black and white. Either you're with me or you're against me. This is what we call splitting. And this happens because there's what we call a fragmented sense of self. Or let's say the patient has low self-esteem and easily can feel criticized and judged when given a perspective that is different from their own. What if the patient feels worthless and useless and they patch over these really painful feelings with a sense of entitlement, grandiosity, and arrogance? And again, by the way, yes, if you're asking, isn't this narcissism? Yes. All of what I'm describing here are characteristics of the narcissistic personality disordered patient. With these patients, we have to adjust our techniques and the treatment approach to be very careful that we are not, again, I know I mentioned this before, but this is what I'm really trying to emphasize, that we are not trying to quote unquote get them to fit into some version of how we think treatment should be. Like, let me give you an example. Take again, for instance, a patient who comes in and complains or pushes back, and they tell you that what you said doesn't make sense. So they push back on things that you say. So in other words, you share an observation with them and they're like, that doesn't make sense. You may have to hear that as a form of communication. And by the way, this is what I mean by you have to adjust. So you hear that as a form of communication. What are they saying? Now, they could be saying any number of things. Maybe they're saying that they're not ready for that kind of comment, that they're not ready to hear what you just said to them. So they object to it. Or, even more valuable, you might want to ask them, how did you hear what I said? Or if you're making an observation on something that happened in their life, how did you see it? Please tell me about that. What did I miss? What did I misunderstand? If what I'm saying is resonating with you, and if you could see and feel that you have an urge to get a patient to see something or to stop doing something, but you don't act on it now because of what we're saying and you want to try this, right? Like, I want to try this. So maybe I won't try to get my patient to come to dialysis or to write their notes so they don't get in trouble with their supervisor. You don't then step into that role, right? One of the psychoanalytic concepts that I used earlier was role responsiveness. And what I'm saying now is if you can consider what I'm suggesting is you don't step into that role. So yes, I'm still thinking about a way to intervene. This is still all about interventions with these challenging patients. But first, before we can be even more specific, because all of this is about a different way to intervene, but let's try to understand, and I'm quoting, role responsiveness, that concept that I used just a moment ago. Okay, so let's better understand role responsiveness. When we have a theory in the back of our minds, we can be more specific with treatment interventions. The psychoanalytic concept of, I quote, role responsiveness, developed by Joseph Sandler, refers to the ways in which both patients and therapists unconsciously engage in roles that mirror past relationships and internalized dynamics. This concept highlights how patients might unconsciously, in other words, they're not doing this intentionally, but they try to impose a role on you, reflecting their own internal object relations and early experiences. Sandler's work emphasized that understanding and addressing these unconscious dynamics can facilitate deeper therapeutic work, helping your patients then integrate parts of themselves that are not in their conscious awareness. You may have noticed a moment ago, now I mentioned splitting, and now I just used the word integrate. So when you are working with personality disordered patients, because of their fragmented sense of self, they tend to split. So when patients are splitting, the goal is integration. And I can't emphasize enough how important this is when working with these patients, because the ultimate goal is to help them develop a more cohesive sense of self. Remember earlier, I mentioned that they split, right? That's, again, I'm just reviewing, but that's the black and white, all or nothing thinking. Either you're with me or you're against me. To me, it's very important to address this because we need two people in the room working together on a problem, right? So addressing unconscious dynamics can significantly enhance the therapeutic process by fostering a deeper understanding of your patient's relational patterns. Like, how do they relate? What role are they trying to put you in? And if you don't step into this role, then you can explore these unconscious elements. So both you and the patient can gain insight into how past experiences shape their current behaviors, such as not attending dialysis, like skipping treatments or not writing up her reports, or retreating into his apartment and not socializing or having any hobbies. So let's be more specific with this, because I really want to try to make this part clear, and I want to make the interventions clear. If you can manage to not step into the role, if you are already in the role, then the goal, right, would be to get yourself out of it. So in other words, if you're already in the role of telling or advising your patient on how to write her notes or how to get organized to write her notes, or how important it is to come to the dialysis, and they should come because if they don't come, they're going to end up sick. So if you could sort of untangle yourself from this position and or not step into it in the first place, because now we're talking about it and it's on your mind, what I'm suggesting then is you are in a much better position to engage your patient's curiosity about the meaning of their communications. In other words, the meaning of what they're doing. Let me give you an example of this. Can you imagine session after session, month after month, a patient comes in complaining about how they're not changing. The therapy is not helping. They are still, and here you could fill in the blank, they're still failing to write their reports, right, at work, and they're falling further and further behind. At some point, you may ask to think about what she's trying to communicate with you. Or can you imagine what message this is sending to me? When you say that you're not changing, is it possible you're also saying that I'm not helping you? And then with that, she gets this, right? And I've done this many times, and typically they get this immediately. And then they're going to complain even further that she just doesn't understand why you can't give her the solution or tell her how to get more organized to write her notes, or why you can't push her to get them completed. So just to make this point very clear, if the patient is complaining that you're not doing enough to help her write her notes, like in this example, right, and is trying to get you to play what? A controlling, I'm quoting this, a controlling role in her life, you immediately have to think, how would any person feel with this patient? Would they want to know more about the patient? Or maybe would they not want to see this patient at all because they feel frustrated with the patient? Perhaps there would be fantasies of stopping the treatment or limiting contact with this patient, maybe try to avoid them. This could be quite distressing. When you are on the receiving end of complaints week after week after week, right, you can be made to feel what? Inadequate, hopeless. But the goal, again, I'm just reviewing, is not to act, not to get the patient to do something, right? Because that's going to be good for you, by the way. Because if you're feeling stuck with a patient, you're going to go into like an action mode because you want to help them. So you're going to take an act or an action. And that's something that's for you. It's not for them. But with all this in mind, I would say to the greatest extent possible to initially sit with the distress, both yours and the patient's. And I'm emphasizing the word initially. And you remember what I said earlier. This is not just passively sitting by. Right? That's why I'm trying to demonstrate to you that you can begin to talk to the patient about what it is they have in mind or what do they imagine, right? It's like for you. What do you imagine? What message do you think that you're sending me? See, that's an act of intervention. There's a fancy word for this too, by the way. This is mentalization-based treatment. This is an empirically based intervention approach that talks about mentalization. In other words, helping a patient begin to think about what somebody else is thinking. All right, we won't go down that rabbit hole. Again, we could delve into that maybe in a future seminar. But you see, this is an intervention. When you start to have genuine curiosity and the patient senses that you're not telling them what to do, you're not trying to take away a symptom, you're freer to imagine. What message is it that you think you're sending to me when you say that you're not changing, right? So the goal is not to go into action, but instead, to the greatest extent possible, to sit with the distress. And then once this distress is contained, in other words, you're holding it, right? And you don't just hold it. It's not like you're a passive punching bag. Another psychoanalytic concept, if you don't mind, is containment also goes with then you sort of decontaminate it. And in other words, you're holding it in you and you're trying to understand what it is the patient is trying to communicate to you, so that this way you can begin to help the patient think about this in a different way. And if you can contain this, if you can hold it, right, and you could detoxify it, that's the word I was looking for, detoxify it, you are now in a much better position to try to say something to her, this patient, about how for some reason she wants you to tell her what to do, to push her, and perhaps even pressure her to write her notes. I wonder why you would want me to do that. You see, this is now genuine curiosity because you're not angry, you're not frustrated, and the patient will feel this, you will feel this, and now you can begin. These are the interventions, and this is you not sitting around passively. Now you are more actively trying to help the patient understand what it is that they're doing here. Actually, once you're free, you can see there are many different ways you can begin to think about what the patient is doing. There are many different ways to think about the non-adherence or, not preparing her notes. When there's space, you and then the patient can learn something new. For instance, is there a need for this patient to make you omnipotent? See you as having all the answers, as this fosters then passivity in the patient. And also this is idealization, as if you have all the correct answers. And this, yes, is another common trait of narcissism. This is a narcissistic characteristic. Idealization and devaluation. Please bookmark that one too. Shoot me a note. Let me know if you'd like to hear about any of these things that I'm mentioning in future seminars, because all of these things we could do a deep dive into. So what you may notice here is I'm falling short, right? I'm not telling the patient, I'm quoting this, interpreting, right? That she's trying to get me to recreate the earlier relationship she had with her father, who would constantly pressure her to study and get good grades. See, I'm not telling her that. I'm also not telling her, but I try to help her try to think about how, perhaps, she was trying to defeat me, right? Or defeat you. So that's on your mind too. You see, that's another piece of it. If you're feeling helpless or deflated, perhaps the goal is to defeat you or to defeat anybody who's trying to tell the patient what to do. Why would they do that? Because this woman in this example felt constantly defeated and could never speak up to her father. This is a triumphant victory over the helper, over you now, as the controlling father, because you are now the one who is made to feel helpless. I don't typically make these links because, as I said this earlier, when we were talking about how we would define the challenging patient, I said one of the things we mention is the patient who does not collaborate with you, or it's not like there are two minds working together. Working on this alliance is the more immediate goal, and in my experience is far more valuable than telling the patient, interpreting, or making that connection that you're treating me like the way you wanted to treat your father, even though it may be correct, right? It may be correct. That's the kind of stuff that I mentioned earlier. That may not put a dent in the way that they're behaving. The more important thing is this alliance, right? Why is this alliance more important? Because then you're helping your patient develop a capacity for thinking instead of thinking for them. Do you see what I mean? There's a big difference there. You want them to develop the mechanism for thinking these things through. If you don't have this, what we call, and I'm quoting again in my field, the therapeutic alliance, the patient may end up feeling blamed or criticized by the things that you're telling them. So that's why building this alliance, helping them develop the capacity for thinking and self-reflection. So you have these wonderful insights, but you don't give them to the patient. The goal is to slowly help engage their curiosity. Okay? All right, look, I think we have to begin to wrap this up. So my concluding remarks will be effective treatment of personality disorders, especially in challenging patients, requires deep understanding of the underlying psychological mechanisms driving their behaviors. By recognizing and addressing unconscious dynamics through concepts like role responsiveness, I hope I demonstrated that this can facilitate profound therapeutic work, helping your patients begin to integrate, remember that's the key word, fragmented parts of their self, because the fragmented self is the underlying problem in the personality disorders, like with borderline and narcissistic personality disorders. This approach emphasizes empathy, self-understanding, right? So you don't get the urge to go into action, remember? And then developing and fostering a genuine therapeutic alliance so that now there are two people in the room, two minds working together to solve a problem. Throughout our discussion, we've defined the quote-unquote challenging patient, and I highlighted the overlap between the symptoms of challenging patients and narcissistic characteristics. Recognizing the signs of NPD is essential. These traits often manifest in behaviors like what I've been describing, what's called non-compliance. That's when you're judging the patient by giving it that name. And I hope I emphasize it's not non-compliance. It's that we need to appreciate the subjectively useful component of a maladaptive symptom. So it could be non-compliance, devaluing you, and making demands for immediate gratification were a few of the examples. Identifying these signs is crucial for adjusting your approach to meet the patient's needs. So, rather than focusing on symptom removal, I find it far more valuable to appreciate the patient's subjective experience and promote long-term change by encouraging them to think about the meaning of their own behaviors. Remember what I said, to become curious about that, and I tried to demonstrate several different ways that I would do that. All of this helps in building a collaborative relationship that fosters the patient's capacity for thinking and self-reflection, leading to healthier interactions and more effective treatment outcomes, such as more integrated and authentic self-expressions. Okay, I hope you enjoyed this seminar and that you continue to tune in to this continuing education series. Remember, I called it a series because I hope you got the sense that there's far more that we could discuss in terms of these challenging personality disordered patients. Like, for instance, I mentioned the grandiose sense of self, and that's something we absolutely have to tackle because that's at the heart, at the core of the narcissistic personality disorder. But we'll save that for next time. All right, if you have any questions, by the way, feel free to shoot them to me, and I will take them up in future seminars. Okay. Bye for now. Disclaimer alert. This continuing education seminar is provided for general informational purposes only. The content presented is not intended to diagnose, treat, or cure any psychological conditions related to narcissism or any other mental health issues. The information provided in this seminar should not be considered a substitute for professional medical advice, diagnosis or treatment. For specific advice or treatment related to personality disorders or any other psychological conditions, please consult with a qualified healthcare provider.